So hi everyone, thank you for joining us today for our online open evening. Hopefully you can all hear me and also the presentation as well. If you're having any problems, please send us a message in the Q&A section. I'm here today with some colleagues, so they'll be able to see if there's any issues, they'll let me know and then we can get them resolved. But hopefully it's all just working as it should be. So first of all, a welcome. Thank you for taking the time out of your evening to be here tonight. The plan is that we'll run through the presentation, which just kind of overviews some of the services that we offer here at Herts Essex, and also gives you a sort of an overview of what a treatment cycle might look like if you were to have treatment with us. Of course, that's different for every patient, but we've tried to sort of use a more sort of standard approach so that you can try to then extrapolate from that what your treatment might look like. We'll then have the Q&A section and we ask you for some feedback. So in Teams, there's the chat option, but there's also Q&A. We ask that you use Q&A tonight because that way we can easily make sure that myself and my colleagues are replying to every question and nothing gets sort of lost in the stream. And then I'll also show you a clinic video, which will just kind of give you a sort of a bird's eye view of what it's like to be inside the clinic, because of course, being remote, we want you to still get to see what it's like when we're here. So what I will do is, I've just had a little note to say that I'm appearing twice on a lot of people's screens. So what I'm going to do is I'm going to try leaving the chat and then coming back, or it could be to do with my settings because I'm working on a smaller screen. So bear with me, I'll just see if I can resolve it without leaving, and then we'll see if it needs to be something where I need to leave. Just waiting for the nods up. Looks like we're all good. Okay, I'm off now. Good. Okay, so less of the me show. So yeah, as I'm saying, so the last thing we'll do is look at the clinic video, so you can imagine that you were in the clinic with us tonight. We also have a special discount offer because you've attended tonight. You're eligible to get a special discount on a consultation, which I'll go through at the end with you. So some hellos. So I'm Gemma Walker. I'm a senior clinical embryologist here at Herts Essex, and I'm joined this evening by Jackie McAdam, who is our fertility nurse coordinator. She's going to be answering the Q&A from home, and also Mana Marks, who's our marketing and wellness manager as well. So she's here too, helping with all the tech issues, and she'll be jumping in as and when for the quick Q&A as well. So a bit of history about Herts Essex. We were founded in 1989, so we've been going for 36 years. We still have the same CEO, so we're very much a consistent sort of family sort of vibe place here. We've had over 8,000 babies born after treatment at our centre, which is lovely. And all of the procedures that we do are performed under one roof. We haven't always been at this site, but either way, now that we are at this site, when you come in, you have all your scans, your prescriptions are here, any of your consultations that are done in person are here, but also the egg collection and embryo transfers are done here if you're having that kind of treatment. So it's all one place to go to. And the clinic itself was purpose built for us. So we've got everything that here is, as it needs to be. It's all fit for purpose, and there's plenty of space, and it's all been thought through. So it's a really nice environment to be in. In terms of services that we offer, we kind of cover the whole range really of fertility services, starting for assessments. So for people who perhaps haven't yet started trying, but are thinking about whether or not they might want to, that can be a really good option. We also do gynecological screening, which I think is becoming more and more important given the long waiting lists that a lot of people are faced with. There's many things we can do for you here as private centre. And if you do decide to go down a fertility treatment route, we offer egg donation, sperm donation, surrogacy for people who need to use donor gametes or somebody's uterus to carry the pregnancy. We can also perform IUI, IVF, ICSI and PICSI procedures, which is really the four main methods of getting sperm and eggs together to try to produce an embryo for you. And we can do all of those here. And we offer fertility preservation, so that's freezing of sperm, eggs or embryos for people who either haven't yet decided whether or not they want to start their family, or indeed for people who are going through some sort of medical care that may affect their fertility in the future. And assuming that everything goes well in treatment, we're also able to offer pregnancy scans and harmony testing for people who are already pregnant and would like some reassurance with that as well. So starting with a fertility assessment, We have a couple of different types of assessment, and it really depends on your background. So generally, if you're attending as a couple, particularly if you are a couple where one person produces sperm and the other produces eggs, we usually ask you to attend twice for that. So it's 2 visits to the clinic. And from that, we can look at both sides of the equation for your fertility. If you are a single woman or a couple who are both female, then we can do a female fertility assessment. And again, that takes 2 visits just because we need to look at things and then wait for results. So on your second visit, you get your results. If you're a single man or if you're in a couple but only the sperm providing person would like to have their fertility assessed, we can do a male fertility assessment. And this includes a semen analysis, with all of the things that you would normally get done on the NHS, but also some additional tests which are really valuable if you're considering fertility treatment. And once you've had the test, we then give you a call and one of the embryologists would go through the results with you and help you to signpost as to if there's any other further steps that you might want to take, or if it's just, okay, so now you know, and then you've got a copy of your report. As I say, we can offer gynecological scanning. This is something that we do for most patients who are having fertility treatment, but can be done on its own. The 2 main kinds that we tend to do are the assessments of the uterine cavity. One of these is called a CIS, or a saline infusion sonography. And what this allows us to do is to fill up the cavity of the uterus with saline, so with salty water, and then we can see if there are any abnormalities there using ultrasound. So in the picture here on the left with the black box, we've got a uterus cavity there, and inside it there's a polyp, and that may need removing before you can safely carry a pregnancy, but sometimes it's just a matter of being aware of what's going on, and no treatment's required. The other treatment that we can do here as a gynae scan is a HyCoSy, and this one is a very similar process, but also it allows the fluids that we pump in to go through the fallopian tubes, and it'll tell us whether or not your fallopian tubes are likely to be open, which is really critical if you're trying to conceive naturally or using IUI. The other thing that we push quite hard here is the concept of being fit for fertility. We know that it's not just a matter of sort of having fertility treatment for many people. If you can make sure that your body is in its absolute peak position in terms of your health and fitness, then your body will make the best sperm and eggs that it can, and consequently will make the best embryos. And this will be really important not only for people going through fertility treatment, but also those people who are trying to conceive naturally. So our website, Fit for Fertility, is linked to our main Herts Essex Fertility website, but is also separated. So you can go on there for tips and advice to kind of help you to get into the best possible position before we start the process of trying to conceive. Now, assuming that you are going to have fertility treatment with us, so we're talking here sort of IVF treatment where we'll be, or IUI treatment where we'll be doing something in the laboratory to try to facilitate your journey. It starts off here with our fertility consents platform. So you'll be sent login details in advance. It's an online platform where you can access a series of videos and information about what the treatment journey would be for you. And that's all set up based on the treatments that you're likely to be wanting. We then ask you to have a look at the consent forms that begin the process. We're a really heavily regulated field. All fertility centres in the UK are regulated by the HFEA. And they require us to ask you for some consents before we can do anything, particularly around how we use your information and your data to keep everything safe. So you'll log in to do that. We also ask for copies of your ID, and this is so that going forward we can make sure that everything that we're saving, everything that we're doing, is all connected to the correct person. And then if you've already had any fertility investigations elsewhere, you can upload those as well. So for example, if you've already had some scans done elsewhere or blood tests taken, you can upload any of that, any reports that you've got, and then that way they're available for our doctor to review. What we don't want to do is go over old ground. So if you've already had assessments that would be exactly the same assessments that we'd be offering you, we don't want to charge you for those. So if you've already got the data, you can send that through to us. The other thing that we encourage you to do at the beginning of the process is sign up for the Salve app. This is an app that we use that you can have on your phone, and it's connected to us in the clinic. On there, we can put all of your appointments. We can also put all of your medications, so you can get notifications of when you need to take certain medications. There's loads of medical information on there that we've written that you can then view and read, so it's sort of in your pocket whenever you want to look at it. And if you've still got questions, you can use the secure messaging feature, which we particularly like in the lab. It allows us to send sort of instant messages, although of course we're not monitoring it 24/7, but it does allow us to communicate securely. So we know that we're definitely talking to the right person because they're coming through from your mobile phone, which is really good when we're dealing with confidential information. Once we've done all of those things, we then get you in for your pre-assessment. This is an in-person appointment and is usually nurse-led. So you'll attend the clinic and we'll take observations from you. So this will be things such as height and weight. Now, this is particularly important because BMI is an important factor in fertility, but specifically if you're going to be having a sedation as part of your fertility treatment, so that would be people having egg collections, embryo transfers under sedation, or surgical sperm retrievals, you need to have a BMI of under 34. And the reason for this is safety. Because we are a standalone clinic, our anaesthetists are only able to safely sedate people with a BMI of under 34. If you're over that, then unfortunately you become high risk. And because we don't have a hospital attached, we're not able to proceed. So we do need to make sure that your BMI is managed and is under 34 at the time that you start treatment. We'll also be taking blood tests. For egg providers, this includes the AMH and thyroid function, because this gives us a clearer indication of how many eggs we're likely to be able to get your ovaries to produce. And if you're a sperm provider, you'll be asked to perform a semen assessment. If you have had an assessment elsewhere, it's often the case that unfortunately it's not going to be comparable with the assessments we do in-house. At Herts Essex, we have our own methodologies for how we do the tests, and although many of them are similar, there are some things that you may not have had if you've had an assessment elsewhere. So still send it through because it's really valuable information, but please don't be surprised if you're asked to do another assessment, just so that we can make sure that we're definitely recommending the right treatment types for you based on your sperm parameters. Once we've done all of that, all the results that we'll have collected from all these tests and from collecting all this information from you is passed on to the consultation. And so the consultant that you see will usually be done remotely. If you'd prefer to have an in-person conversation, that's absolutely arrangeable. Unfortunately, though, we do have a slightly longer wait for those just because it's a matter of getting everyone in the same place at the same time. But generally, these are done online and through the Teams platform. So we send you an invitation code on the day of your appointment. And at that appointment, we'll discuss your medical history, we'll talk you through all of your results, and then come up with an action plan. Now, sometimes that plan is to go away and continue trying because that's the point you're at, but for other people it might be to consider fertility treatment, and we try to iron out the specifics and at least give you the options that might be suitable for you. You've then got some time to think about it, of course. There's no obligation to proceed with any of those recommendations at that point, but once you've got the treatment plan, it's clearer then for most people to try to work out what they want to do. If you do decide to proceed with fertility treatment, you will be required to undertake some screening bloods. So for all patients who are having sperm or eggs collected, you'll need to have HIV, hepatitis B, hepatitis C, and chlamydia and gonorrhea screening. Now, with the first three, it's not necessarily a problem if any of these come back positive. We have procedures in place so that we can still safely treat you. It's just that we need to be aware of your status so that if you are positive for these things, we make sure we put those safety procedures in place to protect yourselves, other patients, and obviously staff working with your gametes. Now, if you are going to be providing eggs, as I say, you'll need to have your AMH done so that we know roughly how many eggs we're likely to get. But people who are providing their uterus, so anyone planning to carry a pregnancy, will also be required to have rubella, full blood count, and hemoglobin electrophoresis. These are particularly important because rubella, for example, if you contract that whilst pregnant, can have serious consequences for the baby. And same with the full blood count. If you have any sort of problems there, we need to know that. And the electrophoresis is important both for pregnancy, but also for people providing eggs because it can pick up some genetic problems. So once you've had your screening, the HIV, Hep B, Hep C, chlamydia and gonorrhea must be still in date when we do the egg collection, or the sperm collection. So that needs to be 3 months before you start treatment, unless you've already had treatment elsewhere in the last 2 years. It's a little complicated, but essentially we will guide you through on this. And what we don't want you to do is have those bloods too early in the process, because then they could expire and you'd need to have them again. So we only take these once we've decided that we're definitely planning to have treatment in the next few months. So as I say, one of the treatment options we can provide is IUI. So this is intrauterine insemination. And what we do here is we take a sperm sample, we prepare the sperm to try to get the very best available sperm collected and concentrated together. And then we put the sperm into the womb at exactly the right time to try to maximise the chances of a sperm and egg coming together. This is particularly useful for people who have psychosexual problems. So if you're a heterosexual couple but you're unable to have sex for whatever reason, then we can get over that barrier by putting the sperm directly into the womb. It's also a good option for people who are using their own eggs and their own uterus and are planning to use donor sperm, because that way we can just take the donor sperm and put it in the right place at the right time. But it is important to bear in mind that with IUI compared to IVF and ICSI, it can mean that you need a larger number of donor sperm samples, which can make it quite costly. So if that's something that you're considering, absolutely worthwhile having a chat with us at your consultation so we can try to make sure that we get you the best option to give you the best chance of success. So assuming that you're going to go for an IVF treatment pathway, this is sort of the bread and butter of what we do at fertility centres across the country. So I'll talk you through the process that we follow. So it begins with your first day of your period. Now, obviously, not everybody has periods, not everybody cycles. So if that's you, then we normally need to trigger this, and that's something the doctor will discuss with you at your consultation. But once you start your bleed, we then get you in within a couple of days to have an ultrasound scan. And at this point, what we're wanting to see is that your ovaries are getting ready for a cycle, your uterus is sort of is shedding away, and then we know that we're ready to begin. By day somewhere between 1 and 3, we'll start your first drugs. So these drugs are to stimulate the ovaries to encourage the follicles to grow. Ordinarily, in a cycle, your body will start to recruit a certain number of follicles. And in a natural cycle, one of them will start to tell the other follicles not to bother, and then you end up with one at the end. In an IVF cycle, what we want is for that one that's doing really well to not tell the others to stop. And this way it encourages all of those follicles that have been recruited to start to grow. And this is how we get more than one egg out. You continue taking these daily injections throughout treatment, usually until 2 days before you have your egg collection. Unfortunately, these medications, because they are hormonal in their nature, can have some side effects. It's often described by many people as being similar to the effects that they get throughout their menstrual cycle anyway, but perhaps a little bit more heightened because we're giving you higher doses. So it's this headaches, mood swings, breast tenderness, and bloating. Whilst we know that these can happen and it's often normal, it's always worthwhile mentioning if you're getting these to us, because obviously we don't want to just assume that this is part of the treatment cycle in case it's something else. So don't ever feel afraid to tell us if you're having side effects. Now, once we've started the daily injections, we then need to scan you to know whether or not they're having the right effect. Most people will have between 1 and 3 scans during this process. And what we're going to be looking for is the ovaries to have started to produce these follicles. So these black circles that you can see here, these are the fluid-filled follicles of the ovary. And generally, we would expect the majority of these to contain an egg. It's not always a one-for-one process, but it is a good indicator of how many eggs we might be able to get. And once we start to see these forming, we don't want your ovary to then ovulate, because then the eggs will be lost into your system. Instead, we need to give you a medication, often called cetrotide, although there are a number of other options that we now use. But all of them, what they're trying to do is stop you from ovulating so that we can then continue to monitor those follicles and also the endometrium. So if your uterus is being planned to have an embryo to come back to it in this same cycle, we need to make sure that that's also developing nicely and getting ready to receive that embryo. After each scan, you usually walk across the corridor and then you'll be seen by a nurse. And that nurse will go through what we've seen this time, what our next steps are going to be, and make sure that you've got enough medications to continue with. So whilst we try to give you all the information that you need throughout, we're also making sure that we're updating you at each stage, because it can be overwhelming and we don't want you to feel that you're lost in the process. Eventually, you'll have a scan where we'll see that the eggs are suitable, the follicles, are suitable size, but also that the cervix is ready, that the uterus, is ready. So here we can see these 3 lines, and this tells us that this uterus has got a nice thick endometrium, which most likely is ready to start receiving embryos soon. So we can then plan you for your trigger injection. So at that final scan, we will tell you when to take your HCG trigger, or other triggers. It depends on which medications you've got as to exactly which trigger you'll take, but we'll tell you what time it needs to be taken. And that's really important because that needs to happen exactly the right time before your egg collection to make sure that when we do the egg collection, the trigger has essentially triggered your ovaries to start getting those eggs ready to be collected. We give you all the instructions verbally, and we also give it to you written, so it should be really simple to be able to follow. But if you have any concerns at all, always speak up. It's really no bother, and we can make sure that you've got all the information that you need. At this scan, we'll also give you the time and date for your egg collection and tell you any information you need about admission. So because this is something that we do under sedation, this does mean that you'll need someone to take you home, things like that, and we'll plan it all through with you. We then do the egg collection, and after this is when things go into the lab. So when you come in for your egg collection, you'll be admitted into recovery, and at that point we take some baseline observations, make sure that you're fit, well and healthy, and you'll also be seen by the anaesthetist at this point, who'll just check that everything is good to proceed. If your partner or yourself are producing sperm on the day, you'll be asked to go into one of our production rooms on site to produce your sperm sample. And whilst that's happening, the person having the egg collection will be sedated. The procedure normally takes somewhere between half an hour to an hour, after which you go back through to recovery, where we wait for you to recover. Most people usually feel pretty much awake and back to somewhere near normal within a couple of hours, but we don't let you go home until we're confident that you're feeling well enough to do so. So after all that happens, these eggs that we've collected, the sperm sample that's been produced, are taken into the lab. Now in the lab, we kind of start counting again. So up until this point, you're probably about day 14 of your menstrual cycle, maybe a little bit more, maybe a little bit less, depending on how your body has responded. But the egg collection day is day 0 for embryos because we currently have no embryos. So we then start counting from there. So on day 0, we've got those eggs, and the first thing we could do with them is egg freezing. Now, this is something that's a particularly useful option for people who are, for any reason, wanting to preserve their fertility. So, for example, if they're going to be having treatment that could potentially impact their eggs in the future, so people going through, for example, chemotherapy, or anyone going through any gender-affirming surgeries that might, or medications that might affect them. The HFEA, our regulator, allows us to store the eggs for up to 55 years. But it's all down to what you consent. So initially you can consent for up to 10 years, and then we sort of roll forward from there. Every year we just write to you and tell you, your eggs are still here, what would you like to do with them? Make sure that we keep that communication open. We know that the younger, to some degree, the younger that we are, the better the quality of the eggs and the number that we're likely to get. The same is true of sperm. But that said, if yesterday was the best time to do it, today is the next best day. So even if you are a little older, it's still something that can be a good option. We offer counselling for anyone having egg freezing because, of course, whilst it can feel like a safety net and an insurance policy, it's not a guarantee that the eggs that we freeze will always be usable in the future, but certainly egg freezing is becoming a safer option. But most likely, you'll probably be having your eggs collected so that we can inseminate them. Now, when we talk about fertility treatment, we often mention the phrase IVF. Now, this just usually means any form of treatment where we have sperm and eggs in the laboratory and we're creating the embryos, we're doing the fertilization in the lab. But specifically at Herts Essex, when we're talking about IVF, what we mean is we're going to add sperm and eggs together in a dish and let those sperms swim their own way towards the eggs. This is the more traditional method of doing things and is only really suitable for people who have normal sperm parameters. So when we do your semen analysis for you at new consultation, what we'll do is we'll let you know whether or not we think your sample is suitable for IVF. If you've had ICSI in the past, which is another form of insemination, we generally don't go back to IVF. And there's always a chance that even if the sample was normal on the day, it can sometimes dip on treatment day. And in that case, we may not be able to still proceed with IVF, but that's not a problem. We can then convert your cycle to one of the other insemination methods to give you a better chance of success. So one of these options is ICSI. Now this is intracytoplasmic sperm injection. And what we do here is we take one sperm and we put it into one egg. This is a great option for people who have lower sperm parameters. So if your count is low, your motility is low, or you have a large number of abnormally looking sperm, we can make sure we select one that looks normal and is swimming nicely. We can choose the best of the bunch for the procedure. It's also the only option really for people who don't have any sperm in their semen. So if you are somebody who has any blockage or any sort of problem in how you ejaculate, we may need to do a surgical sperm retrieval, and then we take the sperm directly. And those sperm don't generally swim as well. So IVF's not a good option, but we can absolutely do ICSI. One of the additional tests that we run on your sperm at Herts Essex is the MAR test. This tells us if the sperm have antibodies against themselves. And that's critical because if they do, then the sperm are likely to get stuck together when we try to do the IVF, and they'll get in each other's way. So if we see this in your sample, we'll recommend you for ICSI. And if you've had any previous treatment where you've had failure to fertilise or low fertilisation, we would usually recommend ICSI the next time around to try to get over whatever the barrier was that caused that. So here's a video, which hopefully will play. There we go. So this is how we do an ICSI procedure. So you can see there are sperm swimming around. There's another one there that's not bothering to swim. And what the practitioner here is doing is they're just searching through the sample to try to find a sperm that they think looks nice and is swimming nicely. And the needle that you can see there is the pipette, essentially, that they're going to use to pick up the sperm. So the first step is to find your sperm, and then we strike it across the tail. And this happens just slightly out of shot on this video. But essentially, we're trying to break the tail so that the sperm can't swim anymore. And this is important because we don't want it thrashing about once it gets inside the egg, causing all kinds of havoc. So we take the sperm up into the needle, then we move over to the next part of the dish where the egg is held. So this egg you can see is mature because we've got that little droplet at the bottom. This tells me that this egg is ready to receive a sperm. We bring the sperm to the end of our needle and we push the needle through the shell and then through the membrane of the egg. And when we do this, because the egg is quite elastic, there's some resistance. So we then pull back on that needle and suck some of the egg into it. This breaks the membrane and allows us then to put all of that back into the egg along with the sperm. And it looks really harsh. When you take the needle out, you can still see that funneling. However, most eggs are actually really robust. And within a couple of seconds of doing the procedure, even the person who did the injection would not be able to say with absolute certainty whether or not they'd already injected the egg. It's quite hard to see the sperm once it's inside. So you have to then make sure that you're keeping these injected ones separate. And we know that the majority of eggs will survive the process. There is a chance that some eggs will not. Around about 5 to 10% of eggs will not survive. We'll never know whether or not those eggs would have been able to fertilise using IVF, for example, but generally because we're only recommending ICSI to people who had a reason to think that IVF would not be a good option, the small risk of damage is actually a risk worth taking in comparison to the potential risks of not actually getting fertilisation at all using IVF. Now, the other thing that we can do when we have the sperm available is PICSI. This is exactly the same as ICSI in terms of the injection. The only difference is that we use the dish like you can see here on the right-hand side, which is coated with a hyaluronic acid solution. Now this one, what we are therefore able to do is see that mature sperm will bind to this chemical, and therefore when we go around to pick up our sperm, we choose the ones that have bound down, and we can be more confident that the sperm we're injecting are mature. We only really use this procedure for people who at their semen analysis have a low HbA score, and that means that at the semen analysis we saw quite a high level of immaturity. But most patients will see HbA scores in the 80 to 90% range. And so therefore, if we do standard ICSI, the chances are the sperm that we're choosing are mature anyway. But if you have a lower score, we want to make sure for certain that the sperms that we are using to put into the eggs are mature. And that's when we would offer the PICSI method to you. By day one, we would expect to see some signs of fertilisation. On the left, you can see here there's just two sort of circles inside the egg, and these two circles are the polar body, are the nuclei, and on the outside you've got two smaller circles which are the polar bodies. These structures together tell me that this egg has got the right amount of DNA, has most likely got the right amount of DNA within it. Certainly, one of the structures in the middle there has come from the egg, one has come from the sperm, and so they've both deposited the DNA that they need to inside. And this is normal fertilization. The picture on the right, however, shows three of these PNs, and this would suggest to me that for some reason the amount of DNA inside is not going to add up to quite what we want to see. And we know that these sorts of embryos are incredibly unlikely to give you a healthy embryo moving forward, and thus incredibly unlikely to give you a healthy baby. So we don't continue growing these. So on day one, once we've done the fertilization check, we give you a call and let you know how many embryos are fertilized normally, and that's the number that we'll continue to culture with. On days 2 and 3, we generally don't look at the embryos as much anymore. In the past, we used to look at embryos every day because we were curious to see how they were getting on, but we actually found that as a sector, we weren't really changing our decision making by looking at the embryos at this point. We were just knowing things, which puts the embryos at risk because you have to take them out of the incubator to do the assessment, and that means taking them out of that lovely warm environment that we work so hard to maintain. However, some patients will be choosing to have an embryo transfer whilst their embryos are on days 2 or 3. Now, generally, we recommend a day 5 embryo transfer for most patients these days. And that's because by day 5, any differences between the embryos are much more pronounced. So it's easier for us to try to select the one that we think gives you the best chance of a baby. But if you're going to have back all of the embryos that are available, so for example, if you only have one, then we can get that back to you sooner. And we can do that on days 2 or 3. And you'll be led by the embryologist as to which day we recommend doing that on. But at this stage, the embryos usually have just started to divide into multiple cells, so we don't get as much information about their potential. So more and more patients are moving away from this kind of transfer because the sort of concern is that if this is unsuccessful, we don't know if that's going to have been unsuccessful because the embryo couldn't cross the next really important hurdle, or if it's because of some other issue that we maybe need to address in a different way. So we get more information by waiting, but of course every patient is different, and for some people having an embryo transfer, doing that as soon as possible, is the most important way to sort of protect yourself and to make sure that you're managing how you're feeling about the whole process as well. The embryo's potential will not be changed, so if we put it back sooner or later, if it was going to give you a baby, it will do it. It's really more about sort of getting more information and also protecting yourselves and how you're feeling about it. On day 4, embryos should be going through a process of compaction, and many times when I show people this picture of this embryo, they assume that they're missing something that an expert would be able to tell you more about. But if we're being really brutally honest, there's actually not much more that even the experts can tell us at this stage. When we see an embryo like this, we can see that it's compacting. You can't see the boundaries of the cells anymore, but it's too early for us to know whether or not the structures it's going to make are going to be of good quality. There is some information that can be pulled from this, but it's very minimal. So instead of looking at the embryos on day 4, we leave them undisturbed, let them continue to grow, and then we can assess them once they get bigger. Now, by day 5, we should see a blastocyst for the majority of embryos. Not every embryo has the capacity to become a blastocyst. It's usually about 50%, but what we're looking for is a structure like the one you can see here on the right. So by this point, the shell has become very thin. This embryo is actually starting to hatch out there at around about 3 to 4 o'clock. And up there at about 11 o'clock, you can see that big nice ball of cells. That's the inner cell mass. And that's the part that will go on to become the fetus, while the rest will go on to become the placenta if it can implant. I would say this is a particularly nice example of an embryo. I've seen some really beautiful babies from some much uglier embryos, so please don't panic if you don't have any embryos of quite this quality, but this is just a nice example of what we're hoping to see. On day 5, we can do embryo transfer for you. So if the plan is to have an embryo put back into your uterus with a view of getting pregnant this time, we can do that. We do them here 7 days a week, so you don't need to worry about when you have your egg collection and whether or not that's going to impact when you can have your transfer. We'll do your embryo transfer when your uterus is ready and when your embryo is ready, regardless of what day that falls on, including bank holidays and the weekends, of course. So you'll be given an opportunity to have a quick look at your embryo before we put it back, but we also take a photograph in advance of that so we can give you that to take away. For some patients, they don't want to take the photograph home with them at that point, because if things don't work out as we hoped, then some people find it quite difficult. So please let us know if you'd rather not receive that. That's absolutely fine. We can keep it on file until you're ready to have it later, or not at all. The other thing with embryo transfer we need to consider is embryo glue. Now, this is a specialist media that has a really well thought through name. Essentially, it's just a culture media with a slightly different ratio of sugars, salts, and different chemicals within it. And we know that if we were to use this for absolutely every patient, it wouldn't significantly increase the number of babies born. But there have been some studies that have suggested that for patients who have problems where the embryos can't implant, embryo glue might be helpful. So because it's, in the grand scheme of things, less costly than many other interventions, we do offer it to everybody, apart from those people who are funded by the NHS. So if you're a privately funded patient, you can choose to use embryo glue, and therefore if you were someone who was likely to benefit from it, we'll never find out because we just used it and you got pregnant, hopefully, and we've never had to go through the process. However, because the NHS has to have limits as to what they can and can't offer, embryo glue is considered to be an add-on by our regulator, because we know it wouldn't help absolutely everybody. So it's not offered for NHS patients. Not everyone will be having an embryo transfer, and even some people who are having a transfer will also be opting for other things on their remaining embryos. And one of these options is biopsy. So we can take a biopsy from the trophectoderm, so from the part that will go on to become the placenta. And you can see that in this picture here on the right. We essentially wait until the embryo is of a suitable size, which not every embryo is by day 5, but we have a look at them. And we suck some of the cells away and cut them off. And then we send those cells off to be tested at a genetics laboratory that we work alongside. And they can look to see how much DNA is inside those cells. Now, PGT-A is probably the most common type that is used. And all we're doing here is counting, do we have the right number of each chromosome that we should have in these cells? And if the results come back to tell us, yes, you've got 2 copies of all 22 plus X and Y, then we can safely say that that embryo has a good chance of giving you a healthy pregnancy. However, it may be that some of the cells or all of the cells don't have the right number inside. And dependent on how many cells are affected and which chromosome we're talking about, that will have a different impact on the embryo's ability to give you a healthy pregnancy. It may be that it can't implant, it may implant but be more likely to give you a miscarriage, or it might be that it would go all the way to a pregnancy that would go all the way to birth, but those children may be affected by disorders such as Down syndrome or Turner's. So we don't generally recommend transferring embryos that come back with an abnormal result. However, before you have any of those embryos discarded or transferred, we usually recommend that you have a chat with our genetic counsellor so you can understand the sort of implications of your decisions. We can also offer PGT-M and SR. These are for people who have known chromosomal or genetic problems. So if you're somebody who already knows that they carry a disease such as things like cystic fibrosis, BRCA or Huntington's, or indeed if you know that you've got a structural rearrangement where some of your chromosomes are stuck together, what we can do is we can screen the embryos for those anomalies and try to make sure that we prioritise the use of normal embryos first. Now, if you have PGT, those embryos will need to be frozen whilst we wait for your results to come back. Some patients will also have embryo freezing after they've had the transfer, because we're only going to be transferring 1 or maybe 2 embryos, but you may be fortunate enough to have 4 or 5 that have grown really well, and we can freeze the extras. And for many patients, and increasingly this is the case, we find that because of the medications that we give you to stimulate your ovaries, we find that it actually wouldn't be safe for you to fall pregnant immediately after having your egg collection. And in these cases, what we would do is recommend freezing any suitable embryos. We wait for your body to recover, and then you have the embryos back later on once you're in a better place to receive them. Now, we can only freeze and indeed only biopsy embryos that are suitably strong to withstand the process. So not every embryo that we have will be suitable for freezing. But what we would do is grade them, assess them, work out which ones we think can be safely frozen, and around about 95% of embryos that go into the freezer will come out with no problem. So there is a small chance the embryo may not survive the thawing process, but that's usually a sign that even though it looked strong at the point of freezing, it actually had something there that meant it wasn't as robust as it appeared. So all of these things can be done on day 5. Oh, sorry, I've jumped one too far there. And on day 6, we again can assess them for biopsy and freezing, but unfortunately we wouldn't be able to do an embryo transfer because we'll have now missed the window for when your uterus was ready to receive an embryo. So on day 6, you'll get a phone call from us to let you know sort of final numbers, whether or not we're able to do any freezing, whether or not we're able to do any additional biopsy, and we'll give you sort of a final summary from the lab. And after that, we pass you back over to the nursing and medical team, who will guide you through the next part of the process. Now, if you've had an embryo transfer, we then need to make sure that we're supporting your uterus so that it can make sure that it's strong enough to continue to try to take on that pregnancy. We usually provide luteal support in the form of different kinds of progesterone. This could be pessaries, injections, or a combination of the both. And your medical team will work out what they think is the best option for you. Some people will have blood tests during this process in order to try to make sure that we're giving you just the right amount of progesterone. We don't want to give you too much because that can have side effects as well. So we make sure we optimize this as a really personalized method to make sure you get just the right dose. And you'll then do your pregnancy test, which will be 16 days after your egg collection. It may be 15 days if that happens to fall on the weekend, or even 17 days if it falls on the Sunday, because what we don't want you to do is test on a weekend when we're not available to support you. We instead adjust this and we make sure that we get an accurate read between sort of 15 to 17 days. We'll get an accurate result from you with most urinary tests, and some people will have a blood test to make sure as well. Once you've had your test, assuming we see those positivity lines, we can then get you booked in for an early pregnancy scan. The image on the left here is around about a 6-week pregnancy. So the little bit that you can see that's sort of a circle within the circle, that's the yolk sac of the embryo, and that's feeding the fetus. And then the little line that's being measured is the fetus itself. And at this point, we try to get you booked in for around about 7 weeks, because by this point we should be able to start seeing early cardiac activity. So we're looking for a heartbeat, and that tells us that the embryo has implanted and that it's viable. If that then continues, we can then get you booked in again, if you'd like to have an additional scan at around 10 weeks. And at this point, we can also offer you the non-invasive pregnancy testing. So for this, we take a blood test from the person carrying the pregnancy, and we're able to read information from within your blood that's actually related to the fetus. So from this, we can screen for things like Down syndrome, Turner's, Edwards-Patau's, Klinefelter's, and even at this point, we can also find out the sex of the fetus as well. So all of these things are things that we can do. Now, I mentioned earlier on that one of the things we do is donation. So we have people, of course, who are using donor eggs and donor sperm all the time. Egg donation is mainly used by people who are getting a little older, and therefore we know that our egg quality decreases as we age. Or perhaps for people who have undergone chemotherapy or surgeries that have impacted their ability to produce good quality eggs. Then if people are going through surrogacy, for example, so particularly for same-sex male couples where neither of you are producing eggs, of course, and you're also going to be needing someone's uterus to help you carry, egg donation often goes hand in hand with this. Sperm donation is, again, used for people who are not producing sperm, people who have gone through medical things that have caused that to stop, but also people who have genetic disorders. Any single person who needs sperm can also absolutely access our sperm donors, and same-sex female couples as well, increasingly using sperm donors. And we have dedicated donation teams here, so if that's something that you're going to be wanting to use, you can just let us know and we can give you more information and guide you through the process. Now, surrogacy is something that we do quite a lot at Herts Essex. We've done nearly 400 cycles since 2012, which is a lot, particularly for a clinic of this size. We have a dedicated surrogacy team. So if you're somebody who wishes to become an intended parent through surrogacy, or indeed wishes to become a surrogate, you can contact them and they'll be able to talk you through the whole process and guide you through. As I said, many of these cycles include using egg donors. And we use surrogacy for any patients really who require it. So anyone who, for whatever reason, doesn't have a uterus that can take a pregnancy. So whether that's heterosexual couples or male same-sex couples, or indeed single men, single women, it's not about who you are, it's about what you do or don't need. So if you need somebody to carry your pregnancy, then surrogacy is a good option. Now, We do two types of surrogacy. One of them is called full or host surrogacy, and the other is partial or straight surrogacy. Essentially, the difference here is as to whether or not the person who's carrying the pregnancy is also going to be providing their eggs. So for many patients, they will use, particularly for heterosexual couples, they'll be creating their own embryos and they just need someone to carry the pregnancy. Whereas for some same-sex male couples, it may be that the person that's going to be your surrogate has also offered to be your egg donor, and therefore we can explore different options dependent on the situation and what you are able to bring into the treatment cycle. Now, funding is obviously a really important thing to consider when we talk about fertility treatment. I think it's no secret that it's not cheap and that also it can be a bit of a lottery. We do have NHS funders who can refer to us. So we're in partnership with 3 ICBs. These are based on where your GP is registered, not your home address. So if you are already in a situation where you know you have NHS funding and you're looking to move address, that's obviously absolutely fine, but we would advise you to keep your GP the same and not update that until after you've completed your treatment, because we wouldn't want you to lose funding by moving out of the area and therefore no longer being eligible. You can get more information about NHS funders that work with us by pressing the button you can see there on our website, and that will take you to far more information about that too. So as I say, this is all based on where your GP is registered. For the North East London ICB, these are the areas that are covered. Then for Mid and South Essex, it's these areas. And for North Central London, it's these. So all of these options are something you can absolutely look to explore with your GP if you think you may be eligible for funding. Now, many people are not eligible for NHS funding, particularly people who have children from previous relationships or people who have had private fertility treatment before. So if you haven't had treatment before, it's always worthwhile starting with your NHS referrers to see if you're able to get funding before you have any private treatment. But if you are in a position where you need to have fertility treatment, then we have other options that you can help with your funding. One thing you can do is you can explore the option of sharing your sperm or eggs. So if you know that you are somebody whose fertility concern is not to do with your eggs or sperm specifically, you can look to see whether or not you'd be eligible to become a donor. And people who do choose to donate are able to therefore help someone else by sharing some of their gametes, but also they can access subsidised treatment themselves as sort of a reciprocal arrangement there. Of course, that's not for everybody. Now, your other option is to make the use of our special offers that we have available. So as I said earlier, we have a 50% discount offer. This is for new consultations that people who have attended tonight book before the Friday, the 12th of September. So a consultation with us to see our doctor, including your pre-assessment, is usually £250, but we'll do this for £125. But unfortunately, you'll still need to pay for your blood tests and semen analyses, as these are kind of separate. So this is for the time that you'll get to spend with the doctor. You'll be saving £125 on that. So if you would like to get booking, you can either let us know via email, or I'll send you all the other links of how you can contact us later. Other fertility funding options that we work with as well to try to help subsidise the overall cost of your treatment is to work with Access and Assured Fertility. Both of these organisations offer financing options, and dependent on your sort of history and your prognosis, one or other of these might be worthwhile for you. It's certainly worthwhile having a look into them, and their websites are available there. You can also access them through our website as well. So at Herts Essex, we appreciate that the whole process of going through fertility treatment and even just investigations for fertility can be really quite taxing. And we want to try to support our staff, our patients, and even, just the community in general. So you can follow us on all of our socials there, TikTok in particular. We had a video that's been seen by nearly 1 million people, I think now. So you can access a lot of the information that we try to give to support people goes out through our socials. But if you are also a member, a patient here, and you come through, our priority is making sure that you've got the support you need. So let us know what you need from us, and we will absolutely be more than happy to try to help you in any ways that we can. One of the ways that we try to help patients is through diet. As I said, we have our Fit for Fertility platform, but we also have access to BDA dietitians. So we know that people who can control their diet, their BMI, and their general health better are more likely to be able to succeed in treatment. And as I said before, unfortunately, we do have a BMI cutoff for being able to do a sedation. So if you're somebody who is heavier and would like some support in trying to regulate your size, then the dietitians can be a really good option for trying to support you through that, and we can point you to the right people for that. So overall, why should you choose us? Well, we've got 36 years of experience with over 8,000 babies, which we'd love to add your babies to the list. We, as I say, have the 7-day-a-week laboratory service, which not every clinic is able to offer. So that's really something to consider looking into if you're comparing clinics. We use an electronic witnessing system, which many clinics now use. We're able to therefore make sure that when we're using your sperm, eggs, and embryos, everything is electronically tagged, which means that we've got that traceability of knowing exactly where anything is at any one time for safety reasons. We will support you throughout your treatment. We can advise you, we can signpost you to other places that you may need support. We also have a counselling service. Patients are eligible for counselling with dedicated specialist counsellors who deal with fertility. And one of the ones that you wouldn't think would be a big thing, but actually is that we have free parking on site. The last thing you want when you're trying to get to your fertility centre is the stress of how you're going to get there and where you're going to park. We're quite well located for that. And I would say that, again, if you're comparing clinics, thinking about the logistics is actually something that a lot of people overlook, but is definitely worthwhile thinking through. We really value your feedback, so please let us know how you found this evening. If there's anything that I've not covered or I've not covered in enough depth or anything you think I've mentioned too many times, please let us know, because the next time that I do this open evening with somebody, I can adjust, and we want to make sure that everyone gets the information that they need. So please help us to help future patients as well by giving us your feedback tonight. These are our social handles. So if you are on any of those platforms, please feel free to follow us. And as I say, we often post a lot of information on there, tips and advice, and just more sort of showing you around the clinic so you can feel more like you've been here even before you have. If you'd like to book an appointment, you can call the number there. That will bring you through to our main switchboard. Lines will be open again tomorrow morning. You can send an email to inquiries@hertsandessexfertility.com and we'll get back to you. We can get you booked in. If you do decide to have a new consultation, so this would really be for anyone who's looking at considering fertility treatment in the near future, we're usually able to get these booked in within 4 to 6 weeks, and we do also offer a cancellations list. So sometimes it can be sooner. And again, as I say, if you get this booked within the next couple of weeks, you'll be eligible for the 50% discount too. Now, the Q&A will go live now, but whilst we're just getting that set up, I will try to show you a video that we have. So if you just bear with me, I'm going to stop sharing my screen so that I can fire that up. So this should now be what you can see. So this is a video of our clinic. Okay, so that was our video, and hopefully that was giving you a bit of an insight into what the clinic sort of looks like. We'll now move over to the Q&A section, so please feel free to continue to write your questions in there, and myself, Jackie and Marna will be going through those now and answering them as best we can. If there's anything we can't answer today, we will let you know, and we'll add you to our list of people to call tomorrow. And we can go through those, and we can consult with any of our colleagues if they're perhaps better placed to give you advice or information on those topics. And from there we will go. So as I say, please let us know if you've got any feedback for us. Thank you so much for joining us this evening, and I hope that was useful for you. All right, thank you. Bye-bye.